webinar at this time, Innovative Strategies for Addressing Hepatitis C in Indian Country, presented by the Office of Minority Health with 3 very distinguished panelists. Our first panelist is Jessica Leston, who is a healthcare advocate, clinical improver, technology enthusiast, and a IHI improvement advisor. She has worked with the Tribal Health Services for 12 years and currently serves on the Northwest Portland Area Indian Health Board. We also have Dr. Jorge Mera, who is a medical doctor and is the Director of Infectious Diseases for Cherokee Nation Health Service. He is responsible for surveillance, policies, and programs to treat and prevent the transmission of HIV and HCV. Dr. Mera also serves as the Director of the AIDS Education and Training Center, AETC, local performance site at Cherokee Nation. Our final panelist is Kris FourStar, who has experience with hepatitis C that is rooted in the Fort Peck Reservation in Montana. In 2009, Kris created a needle exchange in Fort Peck in response to the hepatitis C endemic. He worked for Fort Peck Tribal Health Department for almost 8 years and is well-versed in discussions surrounding the lack of treatment access and harm reduction services in Native American communities. Our panelists will be presenting in that order, with Ms. Leston first, Dr. Mera second, and Mr. FourStar to complete our panel and presentation. Our panelists will discuss issues of hepatitis health disparities and health equity in Indian country, including tribal efforts to implement syringe exchanges and telemedicine, the need for opioid substitution therapy and specialty providers, screening efforts in jails, and the concept of elimination as the ultimate goal in tribal communities. Please feel free to use the chat box on your right-hand side of your screen. We will be taking questions at the end of the presentations, so feel free to offer some questions in the chat box as well. We encourage everyone to have a lively discussion about this issue of hepatitis in our Native communities. And then also we have the handouts listed in the toolbar as well from each of the presenters that is presenting. So we will begin now with Ms. Jessica Leston.
Thank you, Elton. Oops. Okay. So does this show up? Can you see my first slide?
Yes.
Okay, great. Thank you so much. Elton, thanks so much for inviting me and Dr. Mera and Kris to present today. I thank you so much to Dr. Mera and Kris for agreeing to present with me. This is based on a webinar, but improved from that we gave for the National Viral Hepatitis Roundtable a couple of months ago. And I think it's really important that we continue to address hepatitis C, not just in Indian country, but as a nation, because it's an extremely emergent health problem. It's something, everything around treatment is new, and it's giving us a lot of opportunities to really possibly eradicate hepatitis C and eliminate hepatitis C maybe from our communities, but only if we really come together and work towards a solution. It's a really complex problem, and because it's a complex problem, we need to be willing to come up with more complex solutions in order to address hepatitis C in our communities. Like many other infectious diseases and chronic health conditions, American Indian Alaska Native people are disproportionately affected by hepatitis C. So there's a real reason why we need to come together and address it as a community. If you look at hepatitis C just throughout the United States and then other infectious diseases, hepatitis C deaths have overtaken all other deaths from all other national notifiable infectious conditions. So hepatitis C deaths, there are now more hepatitis C deaths than tuberculosis, HIV, and hepatitis and 57 other infectious conditions put together. And we're only just starting to see where this could possibly go. Because as more and more people have had hepatitis C for years now, and are coming up and are experiencing cirrhosis and hepatocellular carcinoma and are potentially dying from it, this number is only going to continue to increase. Prevalence data on hepatitis C is limited, but incidence data is a little bit more readily available of acute hepatitis C. And for rates of acute hepatitis C, in 2013, American Indian Alaska Native people were at about 1.7 cases. That's more than double that of the national average for incidence of acute hepatitis C. And although prevalence data is limited, there is an estimate out there in the literature that puts about 120,000 persons living on reservations that are positive with the HCV antibody. So although it's limited, we do have one source that states that. In another paper, it states that about 10% of persons in the VA cohort have a seroprevalence for hepatitis C. There's also been a 300% increase in hepatitis C-related hospitalizations in American Indian Alaska Native people from 1995 to 2007. So what this means is, like you saw from that first slide, as people have had hepatitis C now for years, 25, 30 years, they're starting to become sick, and they're starting to go to the hospital, and they're starting to actually see the symptoms of their disease, and it's causing ill effects on their health. And then from 2009 to 2013, hepatitis C mortality in American Indian Alaska Native people increased 23%. And what this looked like was 12.2 deaths per 100,000 people, which is double the national rate of 5.0. So all of these statistics, and I'm going to stop there with the statistics, but I think it's important to have in mind just show the picture of the disparity in American Indian Alaska Native people. So there's good and there's bad news, right? The statistics obviously are not good news, but there is the potential for good things happening, right? So we know that hepatitis C can be cured. So although it's this chronic condition caused from a virus, we can cure it. Curing hepatitis C reduces mortality and morbidity, so we can get these numbers down. And then also curing hepatitis C is going to reduce the risk of transmission. The bad news is that hepatitis C is really still largely invisible. It is becoming more and more visible, and we are opening the door to talk about it. So we're creating that space, which is really fantastic. But largely, we still need a lot more conversation in the public with medical providers, policymakers, tribal advocates. Everybody needs to be talking about this a little bit more. It is the infectious disease with the highest mortality, as from the first slide that we went over, and access to treatment is complicated. So the great thing is, right, the treatment now is so much better than it used to be. So we have the potential to cure all of these people, but access to that treatment isn't so easy, and it does take some planning. But the good news is that we can change this. By having conversations, by talking about it more, we really do have the potential to change this. And where do you start? I think the really good place to start is with this treatment cascade, right? So it's estimated that about 3.5 million people in the United States have chronic hepatitis C infection. So what's the first step is that people need to be diagnosed and aware of their condition. The CDC came out with their screening recommendations a couple of years ago to screen all people born between 1945 and 1965 as a start to start screening people who have had hepatitis C for the longest and have the most hepatitis C in their age cohort. And we do that with an antibody test. The next step is to be RNA confirmed. Do this by case management, those people who have positive antibody tests, to get them back in to get an RNA test for confirmation. And then we need continued case management and consultations with experts in order to locally, hopefully locally treat patients that Dr. Mera is going to speak to that. And then prescribed hepatitis C treatment through continued consultation, and then really making sure that we have access to the drugs that can cure hepatitis. And then finally, hopefully achieve sustained virologic response or cure, successfully treated and cured. But throughout this whole cascade, there are these complex problems that are in the background that need solutioning. Communications, systems and strategic thinking, conflict and change management, all of that impacts the cascade and doesn't make it as straightforward and easy as a jump from one column to the next. So the Indian Health Service has started, and we started this back in 2012, looking at the rates for screening all persons born between 1945 and 1965 based on those CDC recommendations. And this was just as a start, but we've really done a fantastic job at getting the screening rates up from 8% to 32% at the end of the year in 2015, and that's the end of the GIPRA year, so that's actually July 1. And then in December of just this past year, screening was at 42%. So this is something I think that clinics and all of the sites, they see and recognize hepatitis C as a public health issue, and so they really are taking it seriously. They really are taking screening seriously. The highest service unit right now has a screening rate of about 72%. And so how did they achieve this? They achieved this by doing a group of best practices, a change package, if you will. And what that includes are having the hepatitis C screening as a reminder in the electronic health record system, having quick picks and automation, making sure that it's easy to order the screenings as recommended, having standing orders so that it's not necessarily the physicians that are ordering these tests. Because it is a recommendation, it doesn't necessarily need to be ordered from the physician. A nurse or a medical assistant can possibly order this with the doctor signing off later. Clear delegation of duties, making sure that in your practice everybody knows who is actually doing the screening. Having formal policy and training on hepatitis C. You know, just because hepatitis C screening and treatment is now recommended in all of the clinics doesn't necessarily mean that everybody's ready to do that. We need to have this communication and training about it. Really clear leadership that states that this is a priority not only for, you know, IHS or our tribe, but for our clinic and for our community at all of those levels. Partnerships with local and national experts like the University of New Mexico's ECHO program and the University of California, San Francisco's Warm Line. And then access to innovation and being able to think outside of the box a little bit for this treatment. Having primary care be leads in treatment, having pharmacy have treatment leads, and then also this teleconsultation. Preliminarily, what does the epidemiology of hepatitis C look like in American Indian Alaska Native people? Well, so we do have a lot of people in this baby boomer cohort that have hepatitis C, just like the national data shows. But we do show this epi-curve split between the baby boomers that have had long-standing infection and then younger, newly infected youth. Younger hepatitis C patients are believed to be predominantly among injection drug use. So that is where they're getting their infection. If you remember the outbreak in Austin, Indiana earlier, like this year, and the related hepatitis C and HIV positivity there. And then our boomer seroprevalence ranges from about 2 to 12% in the service units, and that's with the average of about 50% screening in that cohort. So there was an article published in the New England Journal of Medicine last year now by Dr. Wards and Merman, and what it stated really was that these recent improvements in treatment options for hepatitis C can have this major impact on the health of can have a major impact on the health of everybody, including American Indian Alaska Natives. Direct-acting antiviral regimens have high rates of achieving sustained virological response, or the cure, with few contraindications and side effects. So this is a huge step forward in treatment. It's a major shift. But these drugs have to be accessible in order to have a meaningful health benefit to patients, to everybody. And especially in the Indian Health Service, where we're already underfunded, drastically underfunded, and we can't meet need, there needs to be more conversation about how we are going to actually access these drugs in order to have them have a meaningful impact on our population. And although these DAAs have been cited as being cost-effective, this does not necessarily mean affordable to American Indian Alaska Native patients and the American Indian Alaska Native healthcare system. So if you look at what the VA was able to do with lobbying from 2014 to 2016, they got, you know, $379, $697, $690 million for increased programming and funding for hepatitis C, and then just last year they got awarded about $3 billion over the next 2 years, and this was allocated on top of what they were normally given. So what I would say is, you know, IHS needs that same allocation of extra funds so that we can start to adequately address hepatitis C in our system as well. And you know, we're going to have to do it at many different levels. Like I said, hepatitis C is a very complex problem. It has to do with policy, with funding, with legislation. The cost of these drugs is very expensive, although maybe, you know, it has come down from what it was originally. There are organizational issues. It takes strong leadership to get hepatitis C screening, programming, and a real public health response done. It takes relationship building. There are provider issues that need training and education, as we talked about. Patient issues, like we need to make sure they have access and the knowledge of what's going on. We need more innovation. We need to be able to think outside the box more about how we are going to address hepatitis C. And then there's ethical implications of health equity and social responsibility. You know, human rights and health equity shouldn't be simply vague ideals. They should be guiding principles of our government, of the Indian Health Service, of businesses, of healthcare institutions, to make sure that we have equitable funding for healthcare, specifically hepatitis C. So that's where we are right now. So I kind of give a broader overview. Dr. Mera and Mr. FourStar are going to give much more specific, very interesting and important overviews of the work that they're doing. Thank you so much.
Can you see my slides?
Yes, we can see them.
Oh, okay. Thank you. Let me just... Okay, well, I want to thank the organizers for inviting me, and it's an honor for me to share with Jessica and Kris this panel. And the objective of my presentation is to give you a brief idea of what we started at Cherokee Nation addressing the hepatitis C problem, towards the goal of elimination, and some of the successes that we've had with the hope that someone else can replicate it and improve them with the main goal of eliminating hepatitis C from your region. As a brief overview, Cherokee Nation is located in northeastern Oklahoma. It has 320,000 citizens, but we serve medically about 131,000 American Indians, Alaskan natives that live in this area. And the capital is located in Tahlequah, Oklahoma. So in 2012, I started the hepatitis C clinic. Let me see if I can point. Sorry. Okay. Well, I started the hepatitis C clinic in where you see that red dot in the map, which is Tahlequah, Oklahoma. Cherokee Nation has one central hospital in Tahlequah and 8 outlying clinics, and we have about 900,000 visits per year in the whole healthcare system. Like Jessica mentioned, when we started a telehealth conference system based on the ECHO project, the Extended Community Health Outcomes from the University of New Mexico, we were able to expand care from one hepatitis C clinic in Tahlequah to hepatitis C clinics in 7 areas in the Cherokee Nation. And that expanded our screening and our clinical care efforts significantly. So there are many tools in which you can expand your clinical force. We chose to use this one, and it was very successful for us, and I strongly recommend it if you don't have one in place. So when you're trying to eliminate hepatitis C, the first concept is there are 4 rules that any disease has to meet for you to be able to eliminate it. And I don't have them depicted on this slide, but I'll briefly mention them. First is that the agent you're trying to eliminate does not have to have a non-human reservoir, and hepatitis C only affects humans, so that meets that criteria. You have to have a good screening tool, and we do. We have a serotest for IgG against hepatitis C virus. You have to have a treatment available to cure the disease or eradicate it from an individual, and as it was mentioned before, we have plenty of direct antiviral agents today to do that. And finally, you have to have interventions that can interrupt transmission, and I will mention them during my presentation, and we also have that. So hepatitis C is a disease that it is potentially, we are potentially able to eliminate from a defined geographic area if we implement all these interventions and tools. So the first thing that you need to understand when you're trying to tackle the elimination problem is that there's 2 big components. The first one is to decrease the burden of liver disease. So as Jessica mentioned, we have a lot of patients, especially the baby boomers, who have had hepatitis C for a long time, 20 or plus years, and 30% of them or 40% of them already have advanced liver disease. Those are the ones that you want to treat quickly to prevent them from developing cirrhosis, or if they have cirrhosis, to prevent them from developing end-stage liver disease. And by treating that group of patients, you will decrease the prevalence of hepatitis C significantly. Now, the target for screening in this, the goal is to decrease the burden of liver disease, is basically to screen your baby boomers and any patients with other liver conditions that may accelerate the development of cirrhosis. For example, if the patient also drinks alcohol or has fatty liver or has hemochromatosis or any other disease that causes liver damage, and they also have hepatitis C, doesn't matter what age they are, they're going to advance or progress to end-stage liver disease faster, and you should target those patients for screening and detection early in your program. And the second component that you have to try to do is to expand clinical care capacity. And that's what we did with the ECHO program by training clinicians, especially primary care providers, which are the pillars of eliminating hepatitis C from any community. There's not enough specialists in this country, GI or infectious disease specialists, that will be able to tackle the big burden of hepatitis C that we have in a reasonable period of time. So we train clinicians not only to treat hepatitis C, but also to manage cirrhosis and to screen for liver cancer or hepatocellular carcinoma. and that is a very important component of your elimination program. This is probably the easiest one to do if you have access to medication and training of your providers. The second component on the right of the slide, which is decrease the transmission or the incidence of hepatitis C, it's a little bit more difficult and it will take more effort, but it's doable. And so the target of the population you want to screen for transmission changes a little bit, because the people who are transmitting the disease are people who are actively injecting drugs, people who are homeless and also are injecting drugs. So if you only screen baby boomers, you will miss this population. And I'll show you in the next few slides how we approach this problem. The second is that you need to have a surveillance for hepatitis C, and a surveillance to detect the acute cases. That way you can implement a contact tracing program. So once you detect a patient who just got infected with hepatitis C, you trace their contacts, and that's the way you can implement interventions in those contacts, screen them and treat them if possible. Basically what was done in the Indiana outbreak of HIV and hepatitis C. And that is something that most states are lacking and needs to be done. Education is critical, not only to the healthcare personnel to understand what to make this epidemic visible, like Jessica mentioned, but also to the public health, to the public. I mean, the public needs to understand, and we need to take the stigma away from hepatitis C and teach the public how it is transmitted so they can care for themselves and help us on the elimination program. And the hardest component, but the critical to implement, is harm reduction, and Kris will be talking about this a little bit more. But harm reduction means that you will try, I mean, our ultimate goal is to cure a person who has a substance abuse disorder and make them not use any substances that are harmful for them. But sometimes that's not possible, so at least we try to have them decrease the use of substances, or do it if they have to use or inject drugs, to do it safely or in a safer mode. So that's where opiate substitution programs come in, needle exchange programs, and accessible behavioral health services. And these are critical harm reduction strategies to eliminate hepatitis C. And finally, Jessica mentioned this, treatment as prevention. If we treat someone who has hepatitis C and they are still using intravenous drugs, at least they will not be able to transmit the disease to someone else if we have cleared the virus. When we started our program in 2012, the first 260 patients we analyzed, that we evaluated, we found out that when you look at the red box, that their ages, many of them were not in the baby boomer category. As a matter of fact, at that moment, more than 40% of the diagnosed hepatitis C patients that we had did not fit the baby boomer criteria. So one of the things we implemented, and I think very successfully, is to expand age-targeted screening. So at Cherokee Nation right now, we screen everybody whose age is 20 and 69 years old. And as I mentioned before, we have 131,000 Native Americans that live in the area, and our goal is to serotest 84,000 of these patients who meet that age criteria in the next 3 years. That's 85% of our population, target population. Also, it's important to expand and think outside the box and expand your screening sites. If you rely only on the primary care physician's offices, you're going to be missing a lot of patients, because many patients don't even hit primary care physicians because there's not enough primary care physicians, or because they don't like to go to their primary care physicians. But these patients will consult dental clinics, will go to the urgent care or emergency department if they have a problem, and that's where these are some hot spots that you can start screening programs that have been very successful for HIV when you read the literature, and there's literature coming up that hepatitis C is also, these places are a good venue to screen for hepatitis C. And not only expand the screening sites and expand the age target, but also expand your screening modalities. So we introduced at Cherokee Nation in our hospital, at Hastings Hospital, what we call lab-triggered screening. and I'll explain a little bit more on the next slide about that, and rapid testing, because rapid testing has the beauty that you have a result in 20 minutes or 30 minutes, and you have the patient there with you that you can intervene and give them education, do a viral load, and that way that patient is engaged in the medical care. When we do the send-out test that takes 24 hours for a turnaround result or 48 hours, we have to call that patient back, and sometimes we're not very successful at contacting the patient, or even if we contacted them, many times they don't come back. So having said that, in 2012, if you look at this bar graph and the red and the brick color, in the whole year of 2012, we had screened 509 patients only. So we implemented just education to the medical providers, telling them, well, there's a guideline, CDC guideline that recommends baby boomer screening. And just by educating the providers, we tripled that screening in the year 2013. In 2013, we implemented an electronic health record reminder with the help of IHS, specifically Jessica and Rick Riley, and that made us improve our screening rate, triple them again. And if you look at 2014, we had screened almost 7,000 patients, and this was just by a combination of education and electronic healthcare reminders that you should screen for hepatitis C. So if you look, this slide basically shows in the first part on the left, in 2012-13, what percentage of patients had been screened for hepatitis C, and they are divided in age categories. And the two top lines are the baby boomer category. And just by implementing what I mentioned, we increased more than 6-fold screening rates. So as of 2015, about mid-15, we had screened 40% of our baby boomer population. So that was a big success, although on the negative side, we have to still screen 60% who have not been screened, and we're working on that. I want to share this with you because I thought this is very interesting. It was very productive for our program. So this is 2015, from September of 15 to April of 2016. If you look at the first bar is September, and we had screened 350 patients on that month. Just compare this to what we had done in 2012, that we screened 500 patients in 1 year. So now we're screening almost 300 to 500 patients per month. So in October, we implemented a expanded age targeted screening, and that increased, increased 2 to 3-fold our screening rates from 500 per month to almost 1,200 per month. And on November, we implemented what we call lab trigger screening. What this means is simply any patient who comes into the hospital who meets the age criteria, 20 to 69, if a lab test is ordered by any provider for whatever reason, let's say they order a cholesterol panel or renal panel or a CBC, we add a hepatitis C test serology on that blood. And just by doing that, we went from 1,200 people screened per month to almost 3,000 per month. And we kept that going for 3 consecutive months, January, February, and March of 2016. For reasons that are too long to explain in this presentation, we had to discontinue lab trigger screening, and you can see how it drastically dropped our screening rates. So lab trigger screening, if you can implement it in your system, is a very easy way to ramp up your screening in whatever age target you have defined for your system. When we looked at the patients that were screened through lab trigger screening, interestingly, if you look at the right side of the slide, of the 97 new seropositive patients we detected, 60 were not baby boomers. So if we would only stick to the baby boomer screening recommendation, we would be missing more than half of the patients that are coming to our hospital today with hepatitis C. And another interesting fact is that when we looked at where the patients that had a lab trigger screening positive Hep C result done, where were they coming from? And you can see that 67% were being seen in the urgent care and the emergency department. So it does not mean that you don't have to screen in other areas, but if you really want the bang for your buck and you have a limited screening budget or site, that's the areas that I would focus on screening. At least it's our example, and when you read the literature, there's been several publications in the last year that EDs are hotspots to detect hepatitis C. Of course, you know, other clinics also, we had an interesting number of patients coming from them. So summarizing our screening efforts, education tripled it, electronic health reminders tripled it, and expanded age-targeted screening and lab-triggered screening doubled it or even tripled it. So if we project the rate of screening we're having right now, in 2016, we expect that we will be able to screen 34,000 patients. That's 1/3 of our population. Right now, we've screened about 14 or 15,000 because we're only halfway through the year. But these are the strategies we've used, and does not mean you can extrapolate them to every place, because each place is different. You have to look at your situation. But these are just some ideas that you can work with. Regarding decreasing the burden of liver disease, so screening is the big first step because you have to know who's hepatitis C positive. But once you have someone positive, there's a series of actions that need to be taken that Jessica and Leston just described. So we centralize the evaluation of patients with seropositivity for Hep C. We have a dedicated case manager that will be calling every patient who tested positive and making sure that that patient has been contacted and has been engaged in one of our primary care hepatitis C clinics. Through the the teleconference ECHO program, we trained 8 pharmacists that are able to treat patients with hepatitis C, and 12 primary care providers and 3 new case managers. So our workforce has expanded significantly in the last year or two. Our goal is to treat 85% of these patients and to cure 85% of them. The ones who have detectable viral load. So when we look at our treatment results, this is a bar graph that shows cumulative patients who have been started and completed treatment with hepatitis C. And then you start in January, the first thing that happened there, we had the first direct antiviral agents available in the market. And in July, we implemented our ECHO program, which was basically expanding clinical care capacity. And in November, we had other antiviral agents in the market. And you can see how the number of patients being treated suddenly starts increasing. And in September, we started our elimination program. So as of today, we've treated over 350 patients with success rates that are above 90% of those who have completed treatment and above 80% of those who have started treatment. And this is our cascade of care. When you look at the last part, I mean, the flatter your cascade is, the better you're doing. If you have any steepness in it, that means there's room for improvement. So if you look at the 4th column from left to right, once patients are started on treatment, in this case it's 223 patients, we 90% complete treatment and 90% of those are cured. So that's pretty good. I mean, there's room for improvement, but it's pretty good. The problem is in the first part of the cascade. First, to screen your patients, which is not shown here. But once patients are screened, the first column shows the patients that were seropositive for hepatitis C. To get a viral load, we lose 30% of the patients for some reason or the other. And that needs to be improved. And once we have a positive viral load, there is a delay in getting them into treatment. And the reasons are multiple, and I can discuss it if there's any questions. But it's very important to have your cascade of care because it tells you exactly where your problems are and where you need to improve. So I think this is my final slide. So to decrease transmission of hepatitis C, there's 5 things that we need to do. Education. We have the Oklahoma State Health Department who started a campaign educating the public, and through the ECHO program we educate our providers. Harm reduction, there's 3 things about this, and Kris will expand on this more, but we've started opioid substitution clinic about a month ago. We are in the process of discussing with the legislature legalization of needle exchange programs because they're illegal in Oklahoma, and although the tribes have sovereignty, still there are some problems to fix regarding pharmacists being able to help because they are state licensed. And we have managed, this is very important, to have same-day consultation for behavioral health, meaning if you have a patient in your office and while you're evaluating for Hep C, you find out that the main problem that day is not the Hep C, but the substance abuse disorder, we can get him into behavioral health that same day and help the patient with that problem. Treatment as prevention is very important, and there's been a lot of controversy. Even insurances won't pay for patients who pay for Hep C drugs on patients who are using drugs. Well, we've treated 67 patients who are using drugs, and our virological response is 82%. So we have had good responses to treatment even when they're using drugs. So not anybody can be treated, but most patients can be treated. Acute hepatitis C surveillance is critical, and finally we have a mathematician doing mathematical modeling to tell us where we should invest more of our efforts to improve our elimination program. Well, thank you for your time, and I know it's a little bit fast and compressed, but it's just to give you an idea of the things that we are doing and that other people might be interested in doing.
Okay, thank you, Dr. Mera, for that presentation. We'll continue the panelist presentation with Kris FourStar next. And just to remind everyone, if you can use the chat box to propose any questions that you may have, so we could entertain those at the end of this presentation. So, Mr. FourStar?
All right, thank you, Elton. Thank you, everybody, for chiming in this afternoon. Let me go ahead and get ready here. All right, as Elton said, my name is Kris FourStar, and I'm talking from the perspective of starting a tribal harm reduction program that encompasses syringe exchange. This is up in Fort Peck Indian Reservation in northeast Montana. This is a little map of Fort Peck up way up in northeast Montana. If you can make out the picture here, this is Montana. All right, get into the nuts and bolts of everything here. So the need, you know, just like everywhere else in the country, but also mainstream United States, we started seeing hepatitis C in our prenatal population roughly in the years of like 2003, 2005 through the Viral Hepatitis Integration Project funded through the CDC. And this was actually done through the jails. They had screening through the jails at the tribal jails at Fort Peck. As a consequence of that, the IHS started screening for hepatitis C in all the prenatal visits of prenatal screens in roughly 2005, 2006. From that, we had a positivity rate of 5.1%, and if you remember, roughly was at 1.52% nationally positivity rates throughout the United States. So looking at the rates, comparing the rates, positivity rates of the United States and what we were seeing at Fort Peck, and like Dr. Mera had mentioned, this wasn't baby boomers, this was young childbearing age women, Native American women. And as a result of this, the Fort Peck Tribal Council requested a outbreak investigation. This was conducted by jointly with the CDC and the IHS from Albuquerque. They came up to Fort Peck and did an outbreak investigation. As suspected, injection drug use was at the root of this problem. So the decision on the needle exchange was moved forward. Hepatitis C is always the primary focus of the needle exchange. It was never about the needle exchange because, like today, back in 2008, 2009, it was very controversial. So the primary focus that we kept in the forefront was always hepatitis C, reducing the rates of hepatitis C transmission and getting the individuals into treatment programs, whether that be substance abuse programs or if it was getting them treated for hepatitis C. We started looking around to see how other reservations had done this, and we could not find any other reservations conducting needle exchanges on reservations, any rural reservations. I could be wrong on that, but anybody chime in, let us know that if we are wrong on any other rural reservations back in 2008, 2009. The only reservation that we found at the time was Pima, right there in the city of Phoenix, and which didn't really apply to a rural reservation. So we kind of essentially started from scratch. We at FourPEC really adopted the harm reduction philosophy that really applied to the Native American way of belief of accepting individuals where they're at, because when we really looked at the nuts and bolts of harm reduction, that we accepted individuals where they're at, because no matter what, they are our family members, whether they are sisters and brothers or cousins or aunts and uncles. These are the individuals who are in trouble. They are addicted to something, and they are in a dark place in their life. So when we started looking at the philosophy of it, it really resonated with us on the tribal level. Like I already mentioned, we always kept the focus on hepatitis C, especially when we talked to the policymakers at FourPEC. This would be the Tribal Council. And where to start? Actually, we looked at everywhere nationwide to find another reservation who were doing this type of work, but we couldn't find any. So we started talking with the active users on the reservation. Right at that time, we had about 200 active cases of hepatitis C, so we planned to get a quarter of that population. So we put a goal out there to talk to 50 injection drug users, and we actually reached that goal and talked to 51 injection drug users. This occurred in the winter of 2008 and 2009. And the way we did this was a respondent-driven sampling technique. These are all individuals that participated in the research study that we conducted at FourPEC in 2008, 2009. So we started with an individual that who I knew, who injected, who trusted me. I talked to him. The survey took about 20 minutes. I asked all the questions. From there, he recruited 2 individuals who he used with, and from there they recruited 2 individuals, and so forth and so on. You can see from this network, it got pretty expansive pretty quickly. And all in all, it took about 2 weeks to do all 51 surveys of me asking conducting every single survey on the reservation. And this is another graph that we started. This individual was not part of the original recruitment. He heard of the process going on, the research study, so he wanted to be part of it, but he wasn't recruited in, so we just kind of started him on his own little bar graph there, or his own little chart. And it's not as impressive as the previous one, but there's still 14 individuals on this one. And I know we're crunched for time, so I'll proceed on. After we had all this data in hand, we proceeded forward to the Tribal Council in June of 2009, and we had a lengthy discussion with the Tribal Council on how we would set this up. And Tribal Council approved it 9-1, and we set up the nuts and bolts of the policies and procedures of how this would operate. Essentially, it came down to that it was a 1-for-1 program, that the Tribal Council agreed that we would set up for we would give out 10 syringes, and we would get back 10 syringes. So I'll get back to that in a second here. The second thing we did once we got Tribal Council approval was we proceeded forward talking with law enforcement. On the reservation, let me take a step back as well. Montana was one of the states, I think there's 8 states right now in the U.S. that do not allow needle exchange, like Dr. Mera mentioned that Oklahoma is one of those states. Montana is one of those kind of gray states that do not, it's kind of iffy. So Montana is one of those states. We are on the reservation, have sovereignty, so we push the issue. So as a result, we have numerous law enforcement agencies on the reservation. We had a meeting with the tribal police officer, the city police officers, the county, the DEA were there, and quite frankly, I was very timid to have this meeting with all these law enforcement agencies. I thought they were going to be very stern, and we're going to be very supportive of it. However, I was quite shocked when one of the officers said, anything you can do to keep our officers safe, they're very supportive. And that's one thing that if there's anybody out there that's thinking about doing syringe exchange programs out there in your own community, is to get law enforcement support right away. And you got to remember that these individuals are on the front lines, and they do not want to be stuck with a dirty syringe, just like any one of us. From there, we had an MOU, a memorandum of understanding that we're going to be doing this type of work. It's from a public health perspective. We're not condoning injection drug use, but we're out there to prevent the spread of hepatitis C and HIV and any other communicable diseases around injection drug use. And we had the law enforcement agencies sign on to that. The operations, the nuts and bolts of the actual program. It was one based upon the survey that we did. To actually see how it would actually function. Everybody said that the way it would work on a reservation, a rural reservation, would be outreach. Nobody would want to come into a fixed site location. So we created a 100% outreach-based type of operation. From there, it all operated from straight texting. People would text myself or my outreach worker, and we would make arrangements to go out there and meet the clients. It was a one-for-one program, so we would start the clients off with 10 syringes, and we would get back 10 syringes, and we would keep on doing that work. Overall, we had close to 100 clients, primary clients, and we also had an unknown number of secondary clients. And the reason why we had secondary clients was either they had jobs working for some individual, or they were too scared to come forward themselves, and so we allowed these primary clients to exchange for other individuals who just didn't want to come in and be part of the program. Every client had a unique identifier number. It wasn't their name, they had a unique number, so we could keep track of how many syringes came in and how many went out and their high-risk behaviors. We had an agreement with IHS at Fort Peck. They disposed of all the sharps that we collected. At that time, this is before the lifting of the ban, even pre-Obama's lifting of the ban. And it was all funded by multiple different grants. United AIDS Foundation, Office of Minority Health actually supported we had a grant from them. It was all funded through different various grants. The operations of it from that time, it ran from, as you've seen, June 2009 through January 2011. The reason why it stopped in January 2011 was changing of tribal health directors. The tribal health director resigned at that time, and the new tribal health director didn't see the viability of handing out syringes to active injection drug users. Overall, at that time, we distributed 8,000 needles, and we collected 9,000 needles. So we collected 1,000 more needles than we distributed. Back 4 months ago now, the Fort Peck Tribal Council restarted this program once again under a new tribal health director. This program operated for, it was sat vacant for close to 5 years, and under high demand, the Tribal Council requested it back under the supervision of the new Tribal Health Director. So once again, Fort Peck Tribal Health has a needle exchange program. This was the local tribal newspaper ran an article in February 2016 of the actual ins and outs of the program. That was very nice of the tribal newspaper. But I know we're pressed for time, so any questions? I want to thank everybody for attending and thank Office of Minority Health for putting this together. Thank you, Elton.
Thank you, Kris, and thank you for the panelists. We have about 5 minutes for questions. I have a couple of questions that we received here that we'd like to be able to have answered. And this is for either Dr. Mera or for Jessica. For IHS screening rates, is the amount of eligible screening population that is screened? If so, what do they define as a screening population?
So for the slide that I presented, the measure that we follow are only people born between 1945 and 1965. So it's based on the CDC recommendation for screening. And then it's based out of that same age cohort in their user population that they define using their GIPRA. So it's their GIPRA communities. And this is able to be tracked in CRS, so it's actually on like an eye care panel. So if anybody has any questions or follow-ups of how to get this number, I'm happy to help.
Okay, great. Thank you, Jessica. Another question is, could you speak about IHS or health services of a specific nation? Who qualifies, and how does that a qualifying patient access services? I'd like to pose that to Dr. Mera, specifically to the Cherokee Nation.
So just to make sure I understood the question, how do they have access to the services, to treatment?
Yeah, who qualifies, and how does a patient qualify to access services for treatment? Yes.
Okay, so our policy is to offer treatment to everybody who has a detectable viral load for hepatitis C. And the way we are able to do that is because 85% of our patients will qualify for patient assistance programs. To qualify for a patient assistance program, you do not have to have Medicare, Medicaid, or a private insurance. Remember that American Indians, Native Americans do not need to have private insurance by Obamacare. They're exempt. So if they don't have a private insurance and they don't qualify for Medicare or Medicaid, and that will vary, especially the Medicaid qualification will vary by state, you can apply for patient assistance programs. And you will get the medications 100% of the times if they don't have those three third-party payers. If they have a third-party payer, like Medicaid, Medicare, or private insurance, we have to go through them. And everybody who has advanced liver disease will get covered. The problem may be on patients who have low liver fibrosis scores. Some insurances and Medicaid, and some Medicaids, depending on the states, will not cover that. For that, Cherokee Nation buys the medication for those patients. But that has only been for a handful of our patients that we have to go to that situation.
Okay, thank you for that. This two-part question is for Kris, FourStar. For your exchange program, was any auxiliary healthcare or services provided, or was that just primarily exchanging syringes? And then also, did you see any increases in HCV transmission during the time the syringe distribution was suspended?
The first time when we operated the program, we always wanted to have other services attached to the program where we were able to get those services there. However, now when we are operating the program, we are getting those services there. We're tying into the in-health services tie into ECHO. I believe Fort Peck was the first site outside of New Mexico to be part of ECHO back in 2009. So we're definitely integrating the people who are turning up positive for hepatitis C into ECHO, referring them over there. We are screening a lot more for the high-risk populations for the rapid screenings. And yes, we did see a lot more increase of hepatitis C. I want to say that it was because we didn't have the syringe exchange program going, but you know, the high-risk behaviors have always been there. But yes, we did during those 5 years had huge increases of hepatitis C rates at Fort Peck. Thanks.
Okay, thank you, Kris. thank you everyone for posing your question. I believe we have about maybe 6 other questions that people are posing on the chat box. We'll make sure that we'll be able to get answers from our presenters and our panelists to you through the registration. We have them documented here. Unfortunately, we are out of time for this presentation, but we want to thank our panelists for being a part of this wonderful presentation, first in its series through the Office of Minority Health Resource Center around hepatitis in our minority communities, and we're very fortunate enough to start our series off with the American Indian Alaska Native communities. We will make this presentation as well as the audio available on our website at www.minorityhealth.gov, and we will get you that information once it's available. Again, thank you again to all our panelists. My name is Elton Oswood, and I'm with the Office of Minority Health Resource Center. I'd like to thank everyone for their time this afternoon, and may you continue to walk in beauty. Thank you.